Hello, everyone, and welcome to today's webinar, Strategy in Using Biomarkers for Mild TBI. My name is Maria Chavez Perez. I'm Marketing Manager at Abbott, and I will be your moderator for today's event. I would like now to introduce you our presenter for today. Dr. Martina Pavletić is the head of the emergency department of the Clinical Hospital Center in Rijeka in Croatia, and an internal medicine, nephrology, and intensive medicine consultant. She's a medical doctor graduated from the University of Rijeka with a postgraduate in internal medicine, nephrology, and intensive medicine. This clinical hospital center in Rijeka is the only primary care hospital in a radius of 150 kilometers with specialties in cardiology, traumatology, neurosurgery, neurology, and respiratory. Since the inception of the emergency department 40 years ago, the clinical hospital center in Rijeka has seen a steady increase in patient numbers to the emergency department, and they have continuously innovated to better serve its community. As such, Dr. Pavletić and her team has seen firsthand the crucial need for an objective rule-out tool for traumatic brain injury and reduce unnecessary CT scans and improve efficiencies to the emergency department. And with that, I'll turn it over to Dr. Pavletić. Welcome, doctor, and thank you for being with us today.
My name is Martina Pavletić, and I will talk a little bit about strategy in using biomarkers for mild traumatic brain injury. These are my disclosure statements. And a little bit about my hospital that I came from and that I work entire of my professional life. I live in Rijeka, which is a small town in small country in Europe. And our hospital is a regional hospital, university hospital center that covers 3 counties, a little bit more than 600,000 inhabitants. And it is also the only primary hospital center in the radius of 150 kilometers that works 24/7, and that we make cardiac PCR procedures, neurological procedure for patients with brain stroke. We are also trauma primary center, neurological center. During the COVID pandemic, my hospital was also primary respiratory center for COVID-19 patients. And also in our hospital, we have a long history for Croatia, long history of tradition in emergency medicine with 2 emergency medicine departments in Rijeka and Sušak location. And next year, we will celebrate 40 years of emergency medicine in our hospital. In Croatia, we have emergency medicine specialization from 2011. And today in my department, we have 20 emergency medicine specialists. And during the last 10 years, we have implemented many procedures that are really needed to be implemented in the emergency department in university hospital. And we are very proud of doing them by ourselves all the time. And some numbers about my hospital. We have in emergency department critical care beds, also isolation beds, also high dependency and low dependency chairs. And co-located in emergency department, we have radiology department within the ED with 2 mobile X-rays and 2 X-rays imaging room. The total capacity during the day in the same time in emergency department, we have maximal patient occupancy of a little bit more than 100. So these are also the numbers in pre-pandemic time that we can see that the number of patients each year is rising and rising for something like 7 to 9% each year. I think it is the same whole worldwide. It's nothing special for our country or our town. Also, we can see the numbers of patients that are triaged by categories. The most of them are in the first 3 triage category, and the minority of patients are really not so emergent. And also we have from 2013, so 10 years, now we have our special local protocol for patients suspected for head trauma, and also the different one, the protocol for suspected head trauma in patients with alcohol abuse. Every day we have a little around 3 to 5 patients that comes to our department that are suspected to have traumatic brain injury. In that local protocol that we perform and that we wrote 10 years ago, these are the indications for patients to go to CT that we suspected them to have traumatic brain injury. And as you can see, the criteria for emergency brain CT after head trauma are depending on Glasgow Coma Scale. Each patient that has 13 and less go to the CT scan. The patients that have a 13 or 14 in 2 hours after injury goes to CT scan. Those that have suspected open or impressive skull fracture, sinus symptoms of skull base fracture, those that have post-traumatic convulsions or focal neurological deficit, and very important, those that have amnesia lasting more than 30 minutes after injury. And also for the patients that have some special group of patients, like older than 65 years, those that have coagulopathy or have medication, anticoagulant, and those that have specific injury mechanism, some of them also go to CT scan. And this is the current patient care pathway in ED of my hospital that is also made according to that protocol. So we have a standard operation protocol for CT scan in TBI patient. And the first that patient come to our department, we perform many things, but meanwhile, or among them, we perform also Glasgow Coma Scale. So if the patient has TBI with Glasgow Coma Scale 12 or less, it goes immediately to CT scan. But for patients that have Glasgow Coma Scale 13 to 15, if they have, according to our protocol, indication for CT, then they go to CT, and they are majority of them. The minority of them that doesn't have indication to go to CT scan, we discharge them home without CT. So after the CT scan that can be positive or negative, it's also it leads us in the next way of managing those patients. So if the CT scan is positive, of course the patient is admitted to the hospital, and if the CT scan is negative, then we or discharge them home, or also we sometimes admit them to the hospital due to observation. So it's always very important to look at the clinical picture of the patient. So what do they have in common, all those people in these pictures? Do they have in common traumatic brain injury, or do they have in common a CT scan of the as a procedure? So what I want to recapitulate about CT scan is that indications for brain CT based on clinical factors that we have in our standard operation protocols result in high frequency of negative CT scans. More than 90% of them are negative, and only 1% of them have the need for some neurosurgical intervention. And what is also very important, and it's a result of the previous sentence, that we think that the use of neurological biomarkers in diagnosing mild traumatic brain injury is promising and could reduce CT scanning for up to 40% of the patients. And that's why we performed last year our study that we wanted to see what will be the role of neurological biomarkers in brain injury diagnostics in our hospital and in our department. And I really had to say that I am very satisfied and happy and proud of my staff and many young doctors and colleagues that really helped us make that study and that were really motors of that study and doing a lot of job behind that. And also we made it with collaboration with colleagues from laboratory diagnostics. Together we made this study. So goals in our study with primary and secondary. One of the primary goals was that we wanted to make a validation of mTBI test with two neurological biomarkers that are written here for exclusion of traumatic brain injury. And secondary, our goal were that we wanted to see if our results would make reduction of unnecessary CT scanning. And we estimated that to be up to 40%. And secondary goal was also detect patients with false negative CT result. So we included in our study patients that were 18 years and more, so the adults, admitted to our department within 12 hours of head injury and with Glasgow Coma Scale 13 to 15, so with mild traumatic brain injury. We measured GFAP, and so it's glial fibrillary acidic protein and ubiquitin C terminals hydrolase L1 were measured on a Alinity analyzer, and results were interpreted according to the manufacturer's cutoff values. So if one or both of them were positive, it indicates a positive finding, and both biomarkers below the cutoff values indicate a negative finding. And we also, of course, perform statistical analysis of diagnostic accuracy and some others. So here are results and findings. And we made that study last year from mainly in May and July, June and July. And we recruited 188 patients, but for 149, we had patients that had analyzable data. So as you can see, we had patients that had positive CT, negative CT, positive biomarkers and negative biomarkers, and which is very important, we had non-patient that had negative biomarker and positive CT scan. And of course, we had a group of patients that had positive biomarker and negative CT scan, but it is well known that can occur. And according to our results, we made sensitivity and specificity of the results, and also we had negative predictive value of 100% among them, with high sensitivity, which is also well known from the before. So we concluded in our study that combination of those two biomarkers test is suitable to exclude the need for CT for mild traumatic brain injury in emergency patients, and that is because of the high negative predictive value. We had quite problems while doing our study, or actually we thought we would have problems, and we thought what to do to not having a problem. So we have a staff meeting that we tell anybody that's working in our department, and we have 150 employees in our department, something like 20 specialists, 30 younger doctors and residents, and also visiting doctors from other departments. And it's very high organized department, but with many staff mixing all the time and all around. So we have a staff meeting, and we have the meeting with the nurses and technicians, and we told anybody what we wanted to do in our department. Also, we had animation of our doctors to include the patients. So we made poster with QR code. This is here. With QR code on all of our working stations. So really the staff in working didn't have to think more than scan this barcode. And scanning this barcode pop up the indications for CT scan, and also one questionnaire to be filled up and to make everything all around and 24/7, but just to see how many patients were recruited and enrolled in our study. So after that, with that poster with QR code on each working station, we made daily basis when needed to just please make the study, just please don't forget about it. It's very important for us. And we had departments weekly meetings to see how we are doing with the numbers. So little bit by little bit, day by day, week by week, we enrolled 149 patients. So there are some key learning and challenges that we also had during this study. And what we was challenged how to implement new protocol and diagnostics for patients. This is very important, the group of patients that is CT negative, but neurologic biomarkers positive subgroup, we will see in the future what to do with that patient. And what is very important that also I said before, we don't discharge patients with negative CT if we have clinical indication for observation. So something always is clinical picture, the most important that leads us in how to measure the patient. And what I wanted also to stress always that because of its low specificity and diagnostic accuracy of the test should not be used to confirm the diagnosis. So it can help us to exclude the diagnosis, but it can't help us to confirm the diagnosis. It's always clinical picture and some other diagnostic procedures. So the key learning points are that it can have possibility of reducing unnecessary CT diagnostic up to 40%. And it is faster and safer treatment of patients with mild traumatic brain injury because we don't need to perform the CT scan in those group of patients. And which is very important for the ED as a department, which is always very overcrowded, that it can improve the patient flow in the ED department. This is something for the staff and for the department very important. So what are the challenges in the future and what future could bring us? We applied for financial reimbursement from National Health Insurance Company, and in this part, I can't be proud because we are waiting a little bit more than 1 year for that, but they always said that it is like that with administration, and finally it will come to an end. And also we started to write national guidelines by Croatian Society for Emergency Medicine, which are very near to the end. And after, when the first number will be finished, we can also implement our guidelines in everyday practice, and not only in, of course, our hospital, but in all country, because they are national guidelines. So those national guidelines will have, of course, for mild traumatic brain injury, will be according to Glasgow Coma Scale, and it will be included indications for CT scanning, but also all of them will go to do also neurological biomarkers, those that have indications for CT, and only after that neurological biomarkers will be positive, those patients will go actually to CT scan, and after that the pathway will be the same according to clinical picture of the patient and whether the CT will be positive or negative. So this is my staff that are very happy and young, as you can see. And with that, I thank you for your attention.
Thank you very much, Dr. Pavletić. It was a very informative presentation, and thank you for sharing your experience implementing the new TBI biomarkers in your organization. If you are ready, we have some Q&As that we would like to ask you. Is that okay?
Yes.
Okay, so let's start with our first question. What was the most challenging aspect and key learnings when implementing TBI in your organization?
Yeah, one of the most challenging was, this was one of the biggest studies that we actually performed in our department. So it was because of that and technical how we will make it very challenging for us. And what was also very difficult, and I think that without those modern parts of doing things that younger people are very keen to, and I wasn't, but with barcoding and everything like that, and we had everything on Google table and everything in some cloud, I think it really very, very, very helps to enroll many patients, because every minute and every day we really had our view in study progression. So if we had 2 or 3 days without any patient enrolled, and we have each day 3 to 5 neurotrauma patient in our department, we really just to say in some of our groups and meetings, guys, just please, I know you are all very overloaded with the work and everything, but just please remember, it's very important for us. Just do it, because after that we can apply to our government, we can get those biomarkers, and the life for us would be very easier after that. So I think that those some modern parts of I don't know, it's educational material or some informatic materials that the younger people know. I think that it really helped us a lot. Okay. And you also asked me for challenges, the second part of the question.
Learnings. It was challenges and learning. The learning was the part of the barcode and the implementation of maybe automation of recruiting and all of that, right? Yes, also then challenges.
I mean, challenges, as I see, when we really implement them in our everyday clinical practice, and we will, but we are just waiting for the reimbursement from our government, because we can't do anything, because we are, we have public health insurance, and our hospital is public, so we have to wait for that. But I think that really something that will be very challenging is not to use them in the indication that they are not meant to be used. So in that part, as I always say, they have to be used for patients with mild traumatic brain injury, not the patients with any other indication, because now, like many colleagues from neurology department, they know to come to me, or they ask me, can we use that to, I don't know, exclude brain stroke or something like that? No, we can't do that. There have indications for mild traumatic brain injury, 13 to 15. Coma scale, so don't use them in any other indication. But I think it's always when you try to implement something new, then you have some technical problems in the field that people want to do more than it is meant to be, to help more. But I think this will be challenging, of course, and it will be also challenge to educate staff about the results and what to do with them next. And I think something that will be more, it's not challenging, but the more that we will get from those biomarkers are the group of patients that will have most use of them.
And actually, that was going to be my next question related to that, in terms of what patients' profiles you believe will benefit the most from TBI testing, and which profiles would pose the additional risks, right?
Mm-hmm.
So which would benefit and which would represent a risk to use the biomarker?
Well, one of those that will benefit the most, I think, will be pregnant women, for instance, because of CT scanning, which is not indicated. I mean, not indicated. It's not good in during pregnancy. Okay. And
no, continue. I just said okay.
Okay, sorry. I think that you wanted to ask also. And the group of patients, also the many very old group of patients, geriatric patients, because sometimes because of dementia, sometimes of the general unwellness of the patient, is really very often some of them are coming again and again because they fell in nursery homes, and you don't have enough information, and you don't have enough reassurance that you don't send them to CT scanning. So some of them really, with every time they come back to us, we perform CT scan, because because each admission to the emergency department, we have to look as it is the first one. So this group of patients will really also have a huge benefit of neurological biomarkers.
Okay.
For the staff, we have one group, but this is not for the patient, but for the staff. I always say we have a group of patients with intoxication and alcohol abuse, because sometimes we have to, they are a little bit not cooperable, and we have to talk a lot with them to not pursue, because we can't pursue patients to anything, but to explain them why we have to make CT scanning, and it's sometimes very, very difficult. And sometimes we have to perform CT scanning with analgesic sedation, which has its own complication. So that group of patients will really also benefit with neurological biomarkers, but also the staff, which is very time-consuming dealing with them.
Understood. Yeah, it makes it flow better.
And then again, thinking about your organization as a whole, right? And the impact of implementing TBI biomarkers, do you feel confident it will improve the emergency department operations and patient throughput? And also, what has been the response of the neurologists in your organization with the use of these biomarkers?
Well, I think that it will in our department. Really, I think it's always very difficult to make things new, but it's also very challenging. And I think this is something that in my position and in our practice, we have to do that. This is part of our job, and implementation for any guidelines doesn't come during the night. It comes after days, months, sometimes years. But eventually, there is, I can see any reason why it won't help. It will be maybe sometimes difficult, because each time new doctors, new rotation, you have to tell them the same stuff, the same things. But this is the part of our everyday practice. It's nothing new for the other biomarkers also, like D-dimer or NT-proBNP. It's always telling them that don't reuse them or overuse them, because it's no indication for them. But this is something that we really do every day. And the next part of question you asked me about neurologists. Yes. Yeah. In our local organization, I think that in whole Croatia is like that. And we, when we are dealing with trauma patients, including mild traumatic brain injury patients, which are not for neurosurgical intervention, we discuss and consult neurosurgeons about them. And if we admit them to the hospital, we admit them to the neurosurgery department. But our neurologists are very interested, and also radiologists are very interested when we'll start to implement those biomarkers, because they're very happy to have 40% of CT scanning less, because they are very, very, very busy during the shift. And neurologists, they really wanted to know if those biomarkers in the future would be for something else, like a stroke or some, I don't know, headache, or that could be some trigger for some other illnesses or something like that. And also pediatrician, because right now we can't use them in the kids younger than 18 years old, but our pediatrician are interested in performing some study in their population also. Yeah. Because we have many children, younger and younger, and preschool period that they always fall and hit their heads, and CT is quite aggressive because of radiation, and they would like to have something similar also in pediatric population.
Yeah, I understand. So, well, just one more question, Dr. Pavletić. what to do with a positive biomarker patient with normal head CT scan? What do you do? Mm-hmm.
In those patients, we will, according to clinical picture, if the biomarker are positive and CT scan is negative, as now without biomarkers, we will admit them to the hospital if they will be for observation. If they wouldn't be for observation, we will discharge them home. But we are very interested in that group of patients for some further studies. So, and we are discussing it with our neurosurgery and our radiology department to perform some additional testing like magnetic resonance in those patients to see if there are some subtle changes in the brain that is not clinically important and that couldn't be seen on CT scan. Because if the biomarkers are positive, I think that they are positive. And the only reason why it's not seen on CT scan because it is something very small and which is not clinically important in that time. But in patients that have multiple head trauma, like sportsmen, especially in some aggressive sports, then maybe those subtle attacks, some subtle injuries in the follow-up period during adulthood could have some connections with some other diseases. And I think that this will be some part of future very interesting field of further investigation.
Perfect. Thank you very much. Well, thank you again, Dr. Pavletić, for your time today and for a very interesting presentation and for answering all these questions. This webinar will be available on demand, and we will be providing you with additional information soon on how to get access to it. So everyone, until next time, goodbye.